Hello everyone. Here is an interesting case scenario. You see a patient who was on minocycline therapy, and now after taking minocycline therapy, the patient develops painful raised skin lesions and biopsy shows neutrophilic infiltrates. What will be your diagnosis? And here are the skin lesions you see. These are some erythematous painful skin lesions, erythematous plaques. And here is the biopsy findings. You can see some diffuse neutrophilic infiltrates. So it points out to the diagnosis of Sweet syndrome, which is nothing but acute febrile neutrophilic dermatosis. So the lesions will be painful raised erythematous plaques or nodules, as we see in this case. There are some erythematous plaques here, which is more than 1 centimeter in size. And the most common cause would be drug-induced cause. So the most common drug which causes Sweet syndrome, that is acute febrile neutrophilic dermatosis, is granulocyte colony stimulating factor analogs, GSF analogs, like filgrastim and lenograstim. You can see the drug name usually has this grastim suffix. So from the word grastim, you can say that the drug is granulocyte colony stimulating factor, GRA for granulocyte and STM for stimulating factor. So lenograstim, any drug which ends with the grastim is usually GCSF analog. And other common drugs that causes the Sweet syndrome is minocycline. As we see in this case, our patient was taking minocycline therapy, and other antibiotics like penicillin, fluoroquinolones, trimethoprim, sulfamethoxazole. And the histopathology shows dense neutrophilic infiltrates without vasculitis. Vasculitis will be absent in Sweet syndrome. Only dense neutrophilic infiltrates will be present. So how to differentiate vasculitis from the Sweet syndrome is, in vasculitis there will be fibrinoid necrosis of the vessel wall, which will be absent in case of Sweet syndrome. So that's how you differentiate. And the treatment is usually corticosteroids, and the disease responds well to corticosteroids.